So hello and welcome to pubholic.org. I am Dr. Latasha Headley alongside my colleague, Dr. Indukaku Amulu, and welcome to our platform for open and evidence-based discussions regarding issues affecting our local and global communities. Always remember to keep up with your reliable source, that's us, by signing up at pubholic.org. That's PUBLOLIC.org. And you can also follow us on Instagram at www.instagram.com/pubholic. Today's podcast will cover the topic employing community health workers, auxiliary social work, and public health interventions efforts. This topic will be presented by organization Twinning for Health Support Initiative in Nigeria by Mr. Justice Chukwudi Ulonta and Mr. Daniel Uguanyi.
Before we introduce our panelists, let me briefly provide foundational information about community health workers and auxiliary social work. Community health workers, CHWs, and auxiliary social work have an in-depth knowledge of the community, culture, language, and competing priorities of the population they serve. Cultural humility is an essential element in promoting meaningful intervention approaches that align with the community belief, value, and tradition. The community health workers auxiliary social work curriculum is rooted in culturally competent health education best practices. These practices have been demonstrated in many countries, including Cuba, to increase screening for health conditions to improve members of the community's quality of life. To effectively address health disparity, health inequity, and health inequality, public health work must address health conditions in three domain areas: the upstream, midstream, and downstream. The upstream domain addresses the root causes or risk factors of an outcome or event. The midstream addresses the intermediary determinants of a health outcome, while the downstream focuses on the management or treatment aspect of a health outcome or an event. The community health workers or auxiliary social work best practices primarily support health promotion measures at the midstream and downstream domains. However, in some cases, community health workers or auxiliary social work activities facilitate policy-making initiatives to inform the upstream measures. This public roundtable segment will shed some light on how the work of CHWs inform these three domain areas to improve population quality of life. Now, for our amazing panelists, Mr. Justice Chukwudi Ulonta is the Executive Director of Twinning for Health Support Initiative in Nigeria. Prior to that, he was the Director of American International Health Alliance in Nigeria for over 6 years. He earned a Master's of Science in Social Work from the University of Nigeria. He also holds other certifications in public health, such as Strengthening Human Resources for Health certificate at Harvard University School of Public Health, Boston, Massachusetts. He is a member of the Nigerian National Steering Committee on Social Development Workforce for over 7 years. He is supported by his lovely wife and children. Daniel Uguanyi is a program manager with Twinning for Health Support Initiative. Daniel has over 5 years of experience in health and social welfare, system strengthening, community-based child protection emergencies, auxiliary social work, community mobilization and development, youth sexual and reproductive health, and care of orphans and vulnerable children program intervention. Mr. Uguanyi is also experienced in administrative, financial, logistic aspects of program implementation. I will now turn it over to Dr. Haley.
Thank you. So today we will be addressing the following questions regarding the topic, and how we'll do it is I will ask a few questions, and then our panelists will respond to that, and then we'll later close out and invite the audience to contribute and ask questions to the panelists regarding their presentation. But our questions that we will highlight will be to actually describe the role of a community health worker, impacts of community health workers in a public health setting, medical health setting, and community setting. And we will also talk about community health workers' best practices when it comes to payment mechanisms, core competency training, and school curriculum. And then we'll also talk about twinning personal experiences and current initiatives. Dr. Amalu, do you have anything to add before we get started?
I'm good.
You're good? Okay.
Yes, thank you.
Okay, awesome. So now we will proceed, okay? So again, thank you, Justice and Daniel, for doing this for us. We really appreciate it. We'll get started by asking, can you describe the role of community health workers?
All right. Thank you very much, Dr. Halley and Dr. Melu for having us on board this panel. Right. When we talk about the role of community health workers, of course, they play a role within the local communities. They are local inhabitants, given some level of training on that is to say, basic training in health, basic training in social service delivery, and then they stay within the community and render service to the community population, especially the vulnerable ones. In some countries, they work typically within the district, provincial, and municipal areas. Yes, the role of community health workers, we cannot overemphasize that, no doubt. Now, in such context, they serve as volunteers as the first line response at the community level. And there, they also try to understand the cultural background that exists within the community, and then they work with the systems available within those community environments. Now, when we also talk about their role, they take a greater role in ensuring that they assist people within the community to assess care and service delivery at the community level.
Thank you for that. All right, so can you describe the impacts of the community health workers in a public health setting, and then proceed to continue to describe the impacts when we're talking about a medical setting and a community setting?
Thanks so much. Right, they create a connection between the vulnerable population and the health care providers. Of course, you understand that in certain communities, when it has to do with the facility where medical health provisions are being given, not all who work within, who are the service providers within those communities, understand the needs within the community. Now, the community health workers understand the need within the community. They understand the problems that exist within the community. They create a link between the vulnerable population and the healthcare workers themselves. And sometimes they also have the vulnerable population to assess the needed care within the facility. Now, another thing that they do is that they also assist in providing culturally appropriate health education to people within the community. Sometimes some of the problems that they are facing at the community level include problems associated with nutrition, right? Problems that has to do with lack of understanding about health care services, and sometimes even some services that are available within the community, they do not know how, they do not have the knowledge to access those services. So the community healthcare workers, they work so hard to make sure that they access such service provisions. They have also advocates for underserved individuals. Sometimes you find out that there are available services, possibly from the government, but the community where they serve don't have access to those services. And when that happens, it is the role of the community healthcare workers to direct those, to educate first the population or the community, and then help them access services that are available. So they also collect data, thereby trying to ensure that certain information they have to inform policies, both at the local government level, at the state level. So, and that is a very big role. Sometimes their observations are being taken into consideration in ensuring that better policies that affect people on a positive sense are being captured. And then when it has to do with issues of referrals, sometimes you find out that there are other health professionals that have a sort of service that those in the community really need. But the people in the community may not have access to those service provisions, as we have said earlier. So they serve as a referral link in ensuring that they understand and the people in the community access those services. And that really means that they need to have a knowledge of the kind of services within their disposal or the disposal of those within the community, through what we call resource mapping, trying to have resource directories with regards to what are available for those that they serve within the community at the community level. Now, they also build the capacity of the community to address health issues. Of course, sometimes when there are issues that has to do with outbreaks, they empower them to take responsibility. For instance, on the issue of COVID-19, people who are working as community health workers have the responsibility of trying to help those within the communities to know how to understand how to avoid, how to prevent the outbreak of COVID-19 within the community, thereby educating them on what to do, helping them to take responsibility as community members. So these are some of the activities they empower, the role they play within the community. But however, for them to play this role effectively, they need to be empowered with the right kind of knowledge that are needed in order for them to play their role effectively.
Thank you for that. Very good.
Thank you, Justice. This is amazing information you've provided. I mean, I can't really top that because you went deep inside and actually provided a kind of detailed information about auxiliary social work and community health workers. Now, I'm going to move to question number 3. So now that Justice, you've provided this information, can any of your team please describe the community health workers, auxiliary health work, best practices in terms of payment mechanism, meaning how do they get paid? Describe the core competency training in terms of institution offering trainings for those important auxiliary social work, and also school curriculum or certification required or not required to obtain certification or obtain that type of training to perform this work.
Okay, good evening, colleagues. It is my pleasure to join this program from the northeastern part of Nigeria. The question looks at the best practices pay mechanism for community health workers. One thing that can never be emphasized is that in third world countries like Africa, Southeast Asia, the community health workers are most times the first line of responders to public health emergencies, in the sense that there is dearth of enough manpower to go around the entire population, and because of that, these community health workers come in to bridge the gap in service provision. Sadly, however, many of them are underpaid or not paid at all. For example, in the humanitarian response in Northeast Nigeria, many of these are the forefront of responding to children at risk of violence, abuse, SGBV, and the likes of them. However, while many have indicated interest to do this job, average pay for a community health worker in Nigeria is about $20,000 per month, and that is less than $50. And considering the high standard of living in Nigeria and in other third world countries, this is not motivating at all. And since we have established that community health workers are an important part of public health response in rural communities, to keep them motivated and sustained, and since their work is demanding, it is important that they be remunerated to avoid demotivation. In Nigeria, for instance, there is no legislation that stipulates how much a CHW should be paid in a month. However, this differs from program to program and from community. Most of them do this work because of the passion and the need in their local community, and sometimes they receive nothing. Best practices stipulate that CHW should be compensated adequately since their job is a demanding one, and not just being compensated. The flow of funds to them should be often and regular as a when due. This is beyond the enumeration. Other incentives like leaves, ensuring that they have access to ongoing training is important to keep them abreast of best practices in the field. Sadly, in Nigeria, this is lacking, even though we've established that they are a vital point in the public health response in most communities. Then, for one to be a CHW, beyond the passion, one ought to have skilled and competency-based training and certification. This is important to keep such CHW abreast of current trends in the field of public health, social welfare, because beyond the passion, skill is important. Now, why is this important? Why community health workers are the first responders in many instances, the danger is that they may not stick to best practices and may cause problems where they are working, and still they may not be held accountable under any regulatory framework. In view of this, there is need for ongoing competency and skill-based training to empower these ones to discharge their duties effectively, to ensure that they are up to date in terms of trends in the field of public health and social welfare. Sadly, too, in Nigeria, there are no institutionalized in-service training or ongoing training that these ones could access to keep them abreast in the field of public work. In fact, in the northern part of Nigeria, for instance, in the northeastern part of Nigeria, in the last 10 years of humanitarian response, many of those who are doing this job do not have a platform to access ongoing training in the field of social work. And that is a huge gap. Considering the huge humanitarian needs in northeastern Nigeria, there is non-availability of ongoing professional education in the field of social work. In fact, the available diploma programs are not accredited by the National Board for Technical Education. So best practices stipulate that this one should have access, and not just access, but key into ongoing professional development training. That is what Training for Health Support Initiative is trying to do. Working with educational institutions and governments to institutionalize the social work training in certain institutions of higher learning to ensure that CHWs and observed social workers have access to ongoing professional development training to build their skills in public health and social work, since they are the forefront of most of the response in communities, especially in northeastern part of Nigeria. In fact, in the last 1 month, we have been working in Bauchi and Adamawa with some community health workers to be able to bring this to light, building their capacity as community health workers to help in the HIV/AIDS and OVC response in northeastern Nigeria. So best practices, they should be paid, not just paid, they should be motivated, given other incentives, and then for core competency, there should be access to ongoing professional education, there should be a license, they should be held accountable under the regulatory framework. Sadly, most of this is lacking in Nigeria and some other third world countries.
Thank you so much, man. I don't even know to counter this or even go in and provide any additional information that would top what you just presented. You guys are amazing. But there's something I need to say. I don't think Nigeria is alone on this, because community health workers, auxiliary health workers, or promotores, in some cases in like Mexico or whatever, they call promotores. And in Mexico, promotores are not paid. They're doing this job out of their own passion. But community health workers that receive certification should be paid and should receive adequate compensation, should be responsible for the work they do. Now, I say that you're not alone in the sense that I'm currently working in California in public health, but I'm not going to go in detail for the work I do, but here is the challenge we're having here in California. Even in California, federal agencies are requiring that all states in the United States should have community health workers payment mechanism, core competency curriculum, and certification in a statewide platform. California does not have a statewide certification protocol or processes for community workers. California did not have payment mechanism that is universal for the whole California. They do not have universal curriculum, academic or certification curriculum statewide for community health workers. So this issue is broad, other than just developing countries. Because I say this just to echo what you just said. I mean, community health workers are the, key responders to a lot of issues that might be happening in community. That's why I read the first script about how they know well about their community in terms of culture, values, and stuff. These are important. We should not be addressing 21st century public health interventions using 15th century processes. We have moved into the 21st century, and we should look into this. Again, I have to repeat this. Cuba is one of the countries that had a hand on this already. Doing very well with community health workers, working in the communities, and it shows in their life expectancy. It shows in their infant mortality. It shows in their maternal mortality. Those are the indicators that have shown the efforts of community health workers together and in collaboration with public health and in collaboration with medical experts. Now, that being said, I have to.
Can I make a little contribution on that as well?
Okay.
Especially as it affects Nigeria and why it is a little bit severe when we have to judge or to weigh the problem in a scale. Of course, in Nigeria, we do not have more social workers when we come to say those who provide services to render some help within the community or with the vulnerable population. In fact, we do not have more schools also, and that is also a problem. Sometime in 2013, the Federal Minister of Women Affairs and Social Development, as at that time, as one ministry, they carried out a survey of the number of social workers in Nigeria. As at that time, they used the population of the country at that time to draw a ratio of one social worker to a particular number, and they were able to get about one social worker to over 18,000 Nigerians, those who are professionally trained social workers. So you see that is quite enormous. While even the Nigerian government, the Minister of Women Affairs, Minister of Humanitarian Affairs, have really accepted that community health workers or auxiliary social workers are key health providers or social welfare providers at the local government community, but much has not been done to really encourage this population to render quality service delivery.
Okay, thank you so much, Justice, for that amazing additional information you provided. I'm with you. I'm with you guys, and I'm so amazed by the work your team has been doing. And that's why I also said earlier that the social work, community social workers, auxiliary social work, have, like, where they've fallen is between midstream and downstream. But the information we gather from their work activity actually inform upstream measures. So now going to the fourth question, based on the work your organization, meaning Twinning for Health, have done, what are the current initiatives you have implemented or planning to implement to support the community health workers or auxiliary social work activities?
Thank you, Melu. We make bold to say that Twinning for Health Support Initiative is the only organization at the forefront of social welfare capacity strengthening in Nigeria. In fact, any mention, what comes to people's mind is auxiliary social work. And why are we at the heart of capacity strengthening? It is because without community volunteers, say for example, in recent days there has been emphasis on 90-90-90 in the HIV/AIDS response, that 90% of those with HIV know their status, medication, their variables suppressed. But how can we achieve that without adequate manpower to reach these ones? Community health workers are the first responders working in community to identify these ones, to enroll them, ensure adherence, help them with care navigation, and the likes of them. Thus, in recent years, starting from 2014, when Twinning was set up, we have worked around the clock to build sustainable human resource for health in Nigeria, starting with the STEER project, which is the System Transform for Empowered Action and Enabling Responses for Benefit and Family project. This worked in some states of northern Nigeria, Kaduna, FCT, Benue, Kogi, and the likes of them. Twinning for Health Support Initiative supported the social welfare capacity strengthening aspects of that program. There are those who were in the forefront of testing and counseling. There are those working with the affected families. Twinning for Health Support Initiative works in building the capacity of all community volunteers on that project until it elapsed in 2016. Because of the success of that project, Twinning for Health Support Initiative came on board again under the SMILE project that was led by Catholic Relief Services, CRS, also funded by USAID. That is the Sustainable Mechanism for Improving Livelihood and Household Empowerment project. It works in the part of North Central Nigeria. We have Edo, we have Benue, we have Kogi, we have Nasarawa, and the FCT. Also, we've led the capacity strengthening component of that project, working with community volunteers who work with those living with HIV/AIDS. Because of the success of this intervention in 2016 to 17, Twinning was funded by the United States Center for Disease Control and Prevention Nigeria to institutionalize auxiliary social work, because it was noticed that without institutionalization, the programs that are being done could not be sustained beyond the funding year. However, there is need to have institutions run this program at an ongoing basis so that those who need to access it can reach out to these institutions and acquire training. As a pilot phase, it started with 2 institutions, the Federal School of Social Work, MN Enugu State, and Benue State University, Makurdi. The project also drew participants from 5 different states. And then, because of the humanitarian response in northeast Nigeria, we also noticed that while a lot of organizations are working to ensure that children who are at the risk of abuse, neglect, and exploitation are case managed, we noticed that there is also a gap. This work was just the requisite qualification. And so, because human resource is scarce, there is a tendency to rely on less qualified volunteers who may not even have received sufficient training and who do not possess the necessary competencies to operate in such situations. And these ones may not be held accountable under the regulatory framework. And so we reached out to UNICEF Nigeria. We sent in a proposal. We reached out to them, and they saw reasons with us and brought us in northern Nigeria as a pilot starting with Borno State. As at the first phase, we trained 234 social workers and community volunteers across all child protection agencies in Borno State. Because of the success of that training, we have been asked to scale up to other locations. As of yesterday, we were even in a meeting with them. We have looked at beyond running this training for sustainability, and because of the need for social workers in the insurgency-prone region of northeastern Nigeria, we felt that it is unacceptable not to have any institution running social work studies. And so, to guarantee a steady supply of human resource, we are collaborating with University of Nigeria, University of Maiduguri, and UNICEF. We are pushing for the establishment for a department of social work so that there would be every year steady intake of students, provide this knowledge so that there will always be human resource that are available in that region. Now, the danger is that in the last decade, the humanitarian response has been led by international agencies, and currently there is donor fatigue. Most agencies are preparing to pull out of the region as they transition to development context. The question is, without adequate human resource, when these ones exceed the region, how do we sustain the gains in the last decade in humanitarian response in northeastern Nigeria? And so, even though we finalized the environment polytechnic last year, we felt it is necessary, since the University of Maiduguri has the platform, to advocate for the establishment of a department of social work going forward so that there will always be availability of human resource. And UNICEF Nigeria saw reasons with us, and we are working. That is the next thing we are looking at, while also scaling up to other northeastern states. And then currently, Training for Health Support Initiative is supporting the Integrated Child Health and Child Services Awards that started in 2019 that will run to 2025. We are supporting by providing capacity strengthening initiative for some of the consultants that are being led. Currently, as we are reaching out, we are on this platform from Adamawa State, where we are calling an ASW training course for community health workers who respond who are sub-grantees of the Each Support project led by ProHealth International. And last week we are in Bauchi State. So for Training for Health Support Initiative, the thing is to keep advocating, to keep training human resource. This is the only way we can bridge the gap in service provision in Nigeria. When we look at what we have done, why we look at what we've done and we smile and have a sense of satisfaction, we are careful that satisfaction does not evolve into complacency. There is still much to be done before the end of the journey. If we are to join the other committee of nations in achieving the current HIV 95, human resource is key. And that is what Training for Health Support Initiative is looking at. Training human resource that would work in these communities to assist communities, access care and support for those living with HIV/AIDS and for other public health initiatives. For example, the COVID there with us is not going anytime soon. In these communities, other social workers and community health workers are advocating, educating communities. All of these ones too need to be trained so that they will be updated on current trends in the field and since communities look up to them. So we are also open to further collaborations in this area as there is much to be done. And for sustainability, we are looking at institutionalizing so that beyond the funding phase, these programs will be up and running while people will be free to reach out and access these trainings. These are some of the current initiatives that training have been doing and are currently doing.
Thank you so much, Daniel.
Right. Okay, can I add something to that?
Go ahead.
Briefly?
Yeah, go ahead. Justice, go ahead.
Right. From that presentation, we noticed much of the drive when it has to do with giving quality training to the auxiliary social workers, the community health workers at the community level has only been funded by programs. Of course, when those programs are running, we also understand that most of those programs are looking at certain deliverables, of which the issue that has to do with the training could be just a minute aspect of the deliverable. And much attention will not be given to it because they just want to train these people sometimes to just deliver. And sometimes you find out that what they do is to just give, instead of taking them through the curriculum, they now give them some few training in case management when they are not even skilled to handle issues that have to do with ethical issues associated with their role and their work. So it is often program based, and that is a very big challenge in this regard. So there has not been a direct funding, so to speak, sometimes that is geared towards a pool, a number that are valuable for use at the community level.
Thank you, Justice. You know, one thing I like about this is that when Daniel was speaking, he had mentioned that Twinning for Health is the only organization, nonprofit organization in Nigeria that's known for social work. That filled my heart because it filled my heart in the sense that auxiliary social worker, community social worker is proven evidence-based intervention that works. There's no doubt about this, whether their activity improve quality of life or not. It does, right? So, but also it's sad to hear as well that it's only one organization that have that capacity and skill set to actually be doing this work in a country that is over almost 200 million, going to more with those that are not accounted. But anyways, so this is very, very good discussion that we're having. I will now turn it over to Dr. Headley to continue hosting the rest of the discussion. Dr. Headley.
Thank you, Dr. Amalu. I'd like to thank you both, Justice and Daniel. Are there any, before we open up the floor to our participants, are there any last words that you would like to say?
We have some questions too.
Okay. Well, if not,
Before taking the questions, he asked us any last words.
Yeah.
I want to take this quote from Robert Frost in one of his books. A traveler was on a journey and the horse is getting agitated because the evening and the cold are growing threats. But while he looks back at how far he has gone, he feels satisfied. But then the evening and the cold are a growing thirst. In other words, satisfaction must not devolve into complacency. While we have done much, the thing is, there are many miles to go before the end of the journey. That is, I would say that as my last word. While we have done what we can, there are still much to be done if we are to get it right in Nigeria before the end of the journey. There are many miles still ahead.
I agree. Thank you.
Yes, in a nutshell, the willingness is there, no doubt, on the part of the Training for Health Support Initiative. The readiness is there as well. We are willing to collaborate with achieve this great goal. Of course, one of the things we've been doing, we also work in the area of partnerships. In fact, when Daniel mentioned University of Maiduguri, how we are pushing to ensure that social work program is established there, we are also negotiating with University of Nigeria and Nsukka that have established social work for so many years and have some level of competence in training social workers to mentor University of Maiduguri. So sort of a pet that will create room for visits, sort of exchange visits, and knowledge sharing. We also do that to make sure that we strengthen systems to ensure that they deliver quality service to the community they serve. So we are out there. We are available. We are willing to render this service to the extent that that Nigeria, we can look backwards and we say that we have a pool of workers, both public health workers who are willing to render quality service to the population themselves.
Thank you.
Thank you for that. That's fantastic. I will now, I'm going to stop sharing the presentation so that we could all see each other and engage in a healthy discussion. So stay tuned. All right. I see the chat has been, there's some questions here. So I'll kick it off by representing the chat and reading the questions that are here. So the first question is, please shed some more light on the CHWs. Who trains them? What type of health services do they provide after the training? Are they all volunteers, and do service recipients pay for services? I think you touched upon some of those things, but if you don't mind high level reiterating just to make sure that our attendees understand.
All right, that's fine. As we said before, when we talk about community health workers, we in some areas we can call them as community health. Some areas we call them auxiliary social workers. You also call them parasocial workers. They all fall within the preview of community health workers. Of course, who trains them? In some countries, it's a certificate program that is embedded within an institution, whereby they are being given some level of training. And some health institutions, like institutions that train community health work professionals, also train such people, depending on where the curriculum is embedded. But for Nigeria, while we have a School of Health at the community level training some CHWs, with regards to auxiliary social workers, just as Daniel presented here, we have some institutions where it has been institutionalized. And then with those institutions, train these people, and they are really at the community level. With regards to whether they are being paid, of course, in the course of the presentation, we made it clear that most of the community volunteers or the health workers are program-based community volunteers. And sometimes you find out that a particular amount of money is budgeted for them within the program budget. And when they continue to render services for the program to achieve its goal, they are being paid. But the question is, when the program must have ended, what happened to these people who continue at the local community to render service? That becomes a question, a very big question that is really unanswered. And sometimes what we notice is that at the end of the program, these people are in the community. They render service, yes, but then nobody pays them. And sometimes they are not being motivated to continue with such.
Adding to what Justice has said, taking an example from the humanitarian response in Northeast Nigeria, most of our trainees, while sharing their experiences, said they knew nothing about public health or social work when they were hired as community volunteers because people were not on ground. So the available ones who had that willingness were co-opted to just work. In fact, one of them said he was assigned to shadow with someone for just a week and then sent off to the community. And he didn't even know what child protection was, so to say. So the thing is, it is most programs come in and look for volunteers that will help to achieve the program targets. And maybe most communities, those who could just read and write, are usually the first people that are taken. And then what services do they provide? Sometimes it depends on the details of the program. For example, in the HIV/AIDS response, they look out for those who are infected. They work with the facilities, identify them, take them to the household, they enroll them. Beyond just enrolling them, they escort them to the clinic. They ensure that they practice secondary prevention. They take their ART as a when-due adherence, and they also ensure that to sustain taking adherence, these ones are empowered economically with skills, so that they could, for example, key populations, they are empowered so that they could give up the risky behaviors that they are associated with. Some other ones look out for survivors of SGB within the community, GBV, and link them to care, mostly on the state of the program which they work under. In all honesty, a CV in the insurgency post city of Medugri received just 20,000 in a month. That's less than $50. So he's talking about pay. Now, beyond the program, because the community know them, community still reach out to them and they still refer them, but beyond the program, they receive nothing. I mean, virtually nothing. And are they all volunteers? Yes, most of them are volunteers who, beyond the funding year, beyond the project year, are just on their own. But because of the passion they have, they keep referring these ones. What type of training? The program determines what type of training they give them. For example, they can give them training on PSS, give them on child protection, on HIV testing, on case management. But then this is barely sufficient because they lack the basis of social work process and ethics. And they lack the skills. There is no comprehensive training. And even if these ones want to access trainings on their own, there are little or no ongoing professional training that they can access. So shoes are just, in fact, in the last season when I started in 20% as a community volunteer, most of my certifications, I use the platform public health e-learning and learning at my pace to get certifications I have, because there were literally no training available except the social work training, which I was trained in 2014, the 2 phases. Apart from that and the online training I trained at my pace, there was virtually nothing. In our days, there was no money. We worked for the passion. Yes, we just worked in the communities where we stay. There was literally nothing for them. So those who are not opportune to be part of programs earn virtually nothing. They support themselves and they are demotivated. and that affects the output of the job.
Okay.
Thank you
so much.
Thank you so much. Who wanted to speak?
So, Dr. Melu, it's Dr. Waka.
Okay,
Thank you so much.
Thank you so much. I was going to actually ask you because I saw your comment that you wanted to add something. Go ahead.
Yes. So thank you, presenters. You guys are doing a very good and very useful job. And the way you've taken time to explain what you do is commendable. So from this last text, because initially I was confused at who these community health workers were and social auxiliary workers. But from the last explanation, I actually got what is, Nigeria's health system is a little diverse. Okay, I say it in the sense that there is the public health system, and then there is this private health system that supports almost every facet of primary health care. And from the last explanation he's giving us, I now understand that what you people do primarily targets the private parts of Nigeria's health system, which is commendable, very commendable. Because why I say it is because whenever healthcare is talked about, especially in the private setting, it normally refers to the clinic setting where a patient comes into, to see a doctor or a care provider and receives care and goes. Nobody talks about health extension services that's going into the community, live within the community, learn, get their trust. And therefore, they can confide in you and you provide preventive services, both, health and mental health services. So now comes my question or my contribution. I know there is within the primary health care that is managed within the local government health boards. Most local governments in Nigeria have their departments of health. And if within those departments of health, they hire and they retain community health extension workers. And those workers are hired, they are retained based on going through a 1 year or 2 year training in School of Health Technologies. Most states have School of Health Technologies. So why I'm saying this is that could there be a way you can, identify and collaborate with those kind of people, or even the state or local government, to help sustain what you are doing? Because I know that if they come in and you pull resources together, your activities will be very much more improved. So that's one angle. And I also know that in those health departments of local government, they have social work units. In fact, while I was, because I worked as when I was in Nigeria, I was heading a primary health care center. And we had, because it was attached to the local government, we had social care workers that come to the clinic on weekly basis to learn about some of our patients that would need social health visits. And they will go out. And so in such a way, such services we are provided. When, your organization tries to find out these already established systems and then try to cooperate and then, improve your services. That's what I had, the little thing I had to contribute. Thank you.
Thank you, Dr. Mwaka. So either Justice or Daniel can take the question.
Okay. 1 second. So based on the discussion that we had, I think we answered Ms. Hunter's question. And Ms. Hunter, correct me if I'm wrong. Your question was regarding do they need to keep the credentialing as a CHW? And I think in so many words throughout the conversation, it was answered.
Yes, it was. Thank you.
Okay, perfect. And now we have Florence. Do you have housing issues? And if so, what are the programs that can help members in the community?
Also,
So
Dr. Headley, how do you want it? You want them to answer and then go to Dr. Marcus?
Right.
Okay, good.
No, okay. Dr. Marcus, he said that he wanted to add, but I think we already did that. That's why I skipped it. He wanted to add to the conversation.
But he asked about 2 questions too.
Oh, okay. Well, we can go back to him after Florence, so everyone, can get it.
Go ahead, Florence question. There are housing issues, no doubt, and these have also been identified by these auxiliary social workers at the local community. Sometimes within the community where they work, observe that there are issues of protection on the part of children when it has to do with housing. And when that is the case, they also look into what the program that they serve has in place. With that, they could solve such problems. On some cases, they have really linked with some philanthropists who are willing to do something in order to alleviate them housing issues. And sometimes you find out that some of the housing problems might just be as a result of displacement. Yeah, it's part of the country where there are issues of displacement as a result of insurgency. Yeah, there are a lot of children and families that are having housing issues. Some are within the IDP camp. It's not really that they are comfortable being there, but that is what is available for them now. So while they are working with the government in trying to provide a temporary accommodation for them and to solve the security issues within their communities before they go back. Some, when they are going back, they find out that really their houses have been raided and they don't have houses again. So some the community auxiliary social workers continue to find out, based on the resources available, those who can provide those services. Sometimes it's not often easy.
Thank you.
Okay. Let me respond to some of the things that can say.
Okay.
One of the things in a program for sustainability is working with government partners. Are you guys still with me? Have you lost me?
No, I'm hearing you. Yeah.
Okay. So we work with government partners. In fact, in all the states that we have worked, we have done social welfare officers, state social welfare officers to be part of our training, because the consideration for appointments into such positions in Nigeria is not based on academics. You know how the Nigerian system works. You could be recruited because of who you know or because of a need, and then sent to the social welfare department. So some of those that do not even have the requisite qualification. So in all of our programs in all the states we work, we partner with government partners to have social welfare officers trained. I'm also aware that there are CUES, Community Health Extension Workers program in School of Health Technologies for like 2 years diploma program. Yeah, but this CAWs looks at those who live within the community without even having the basic knowledge about what they are doing, not the ones who have accessed the 2-year diploma program. And then beyond accessing this program, some of these ones who are retained at the local government level, you know how local government work, it might be one health center or one facility that is working. Because I also have a family member who work in some of the cottage hospitals. They are even not available there. If you go there, maybe in a week, they open up once in a week. But yes, we can collaborate with them, and we've done that in the past. But the attitude of government partners is one thing too, and that is why most programs go out and find their own volunteers who help achieve program targets. But yes, as you have said, it is an area that we could look into, but we have done this in all states that we work. We've partnered and even included state social welfare officers in part of our training. For example, in Borno State, all the 35 social workers of the Borno State Ministry of Women Affairs were part of our training. They make up that 234 that we are training in Meduguri. Because even when partners exist in the region, the social welfare officers are there as government partners to keep responding. So, but because you know that many of them do not have degrees in social work, all of them, 35 of them, will always collaborate with the government for legitimacy and sustainability and program ownership. We've always collaborated with them in all of our programs. Yes, but we can still do more, as he has said.
Yes, to buttress that point, the concept cannot be sustained without involving both the local government, the state government. In fact, in certain areas, we try to create a sort of system of reporting so that the activities that are being implemented at the local community will be reported all through the state level and possibly at the federal level. As we said earlier, the Ministry of Women Affairs and Social Development, although now being divided into Women Affairs and Disaster Management and Humanitarian Affairs, they acknowledge the need for these auxiliary social workers. Of course, at so many areas and certain communities, based on programs, as we said earlier, they render quality service. And as Daniel emphasized, when you go to the local government level, Dr. Mwaka, the people you mentioned, the social welfare units within those local government areas, sometimes when you go there, you don't see anybody. Apart from the fact that you don't see anybody, just as we said earlier, posted there, know nothing about service delivery and what should be done. They have no work plan with regards to what they want to achieve. They do not coordinate activities of those who are the local communities rendering services. And these are some of the things we try to do over time in every state whereby we work, working with them and trying to create a link between them and those at the local community. Let me give you an instance. In Enugu State, we train so many local people at the local government areas, including people who are social welfare officers at the local government level. So while training them with the volunteers, we also train those who are working at the local government as supervisors, using some segment of our program that is our supervisors curriculum, to train them to be able to supervise these people at the community and at the same time collect data from them that could inform policies at the community level. I don't know if I'm being heard. Can you hear me, please? Yes. Okay, so that inform policies at the community level. So when we look at, hello?
Yes.
Hello?
Yeah,
we hear you clearly.
Hello, can you hear me?
Yeah, you're fine.
Okay, so when we look at the services that they render, you find out truly that they are they cannot succeed independent of those at the local government. In fact, one local government in Enugu State, the local government, we recall the chairman of the local government expressing some level of joy over the activities of these people, and even suggested that he would work towards ensuring that he has absorbed them within the local government system. So these are some of the things that we do. And with regards to incorporating the government into it, just to stress the point that we cannot succeed without the government being part of our program.
Thank you.
Thank you for that. I know Dr. Nwaka wanted to comment or had a couple of questions. We'll cover his comments and questions, and then we have 3 more questions that we want to move through and before we close out.
Can I make a comment real quick?
Sure.
So my comment here is that through your presentation, you have emphasized that most of your funding, if not all the funding, are coming from international agencies. And now this struck me very well because what is the plan in the absence of the funding, international funding? What is the plan to be able to sustain this? Because all this stuff we're talking about right now boils down to funding, right? I don't know if it's integrated already into your policy that you're promoting so that the federal government of Nigeria will actually take active part in terms of actually supporting this work that you're doing. Because at some point, international agency might not fund the program, and then what happened? You look at all the progresses you've attained, what happened to that? The obvious answer is that it's going to disappear. So if you can quickly, because right now we are at the nick of time, we are 14 minutes past, just quickly touch on that so we can move on to the rest of the other 3 questions. However, if we cannot answer those 3 questions, we can actually send you the question letter to answer, and we can share it with the participants.
Okay, thank you, Dr. Melu. I heard you right there. Sustainability has been at the back of everything we do, and that was why starting from 2016, we have worked to institutionalize the training. These institutions will run this program and those who want to access it. However, one issue is the institutions themselves being abreast with current trends in the field. So what we try to do is to link them up with the National Association, a platform that will ensure that they are abreast with current trends. In Enugu, in Benue, in Borno, currently in Kano and Bauchi and Adamawa, in each of these states, we are working to institutionalize. While we have done that in Enugu, Borno, and Benue, then for this year, within these 2 months, we have been looking at 2 institutions in this northern state that we're working to domicile the training, so that even beyond the funding phase, they begin to run it and ensure that those who need it access it. Then I saw a question from Florence there. Are there foster homes available for troubled children? In Nigeria, yes. However, we are discouraging that. We are promoting reintegration of troubled children into families. You know how the Nigerian situation is. Some of these troubled homes have become a means for trafficking children. And apart from that, best practices have proved that children thrive well when they are reintegrated into families. In fact, that is the priority now in all programs involving children, reintegrating them to families, yes, instead of to foster homes, because eventually they will have to outgrow the home, and then what do they do from there? But when they are treated as part of the family, they see that as their own, and they have a perfect platform for nurture and attachment, and they grow up to be productive members of the society. Sharon Hunter also asks, do they only work with those who come to the clinic or the entire community? They do both. The other part of it, I do not think I understand that question. How do you determine priority of need regarding SDOH? Maybe if she clarifies that. And then
social determinants of health, and she had to leave. She's actually my student, and she owes me some work, so she logged off. But we will. I'll reach out to her, and we'll get her answered. At a later date.
Are there resources to assist troubled children with mental health and drug abuse? Well, there are agencies working in this area. But then the problem is sustaining these interventions beyond the funding years. For example, in northeastern Nigeria, children in conflict with the law, mental health and drug abuse is on the increase. I know there are agencies who are implementing and intervening in these areas, but then beyond the funding years, beyond the end of the program, what is the way forward?
Right.
Yeah.
Go ahead, Dr. Haley.
Oh, I was going to say this was great. I've learned a lot too through your presentation and all the questions that were presented and comments. I appreciate it all. Is there any last words before we close out? We could talk about this some more, and this is very engaging. I don't want to neglect or miss anybody. We're all about the people here, so just making sure as everyone can.
Thank you, everyone, and it's nice having this interaction. As an organization, 24 Hours Support Initiative, as we said earlier, that willingness is there, and we also have the expertise to coordinate programs towards ensuring that the right kind of skills are given to those community volunteers who are rendering service provision. In fact, in one line with Sharon Hunter's question, they just as Daniel answered, there has been they serve as a link both to the community and to the facility. So they are in the middle. While rendering services within the community, they link those who need certain facility response or certain facility services to those facilities, and also provide information to the people in the facility. So when you check generally, they render quality service. They even promote policies. So these are the kind of health workers that we want to ensure that we sustain within at the community level in order to provide quality service. So for us, we are open, we are available for collaborations in this area and in other subsequent areas. Thank you.
Thank you, and we appreciate Twinning for Health initiative, Health Support Initiative, for coming out. Thank you so much, Justice, Daniel, and Dr. Imba for participating with us, and we definitely look forward to future endeavors with your organization.
Thank you very much.
Just don't forget that the purpose of Public is to have a healthy discussion like this to improve healthy people and healthy environment. Thank you so much.
Thank you.
Thank you. Have a great day.